I'd like to thank the organizers for inviting me to give this talk. And as a pediatric intensivist as well as a hematologist, it gives me great pleasure to talk about this topic. Before I begin, I'd like to find out from the audience whether you think thrombosis is a significant problem in your pediatric ICU by a show of hands. Yes. Okay, I'm actually quite surprised because I thought that I would see a lot less hands. So for the purpose of this talk, I will talk about venous thromboembolism due to the time constraint. I have no conflict of interest to declare. And we all know that in pediatrics, the incidence of VTE, or venous thromboembolism, is very low compared to the adult population. This is actually shown in many epidemiological studies. In this study, this is a large study that looks at a 25-year population-based study in USA. And they only have 4 patients under the age of 15 years. And you can see that the incidence rises greatly after the 4th decade. However, for us who work in the pediatric intensive care, we know that critically ill children are at a lot higher risk of VTE compared to the normal population. Despite this, there is actually a paucity of pediatric literature, and a lot of what we do in terms of management of our patients is extrapolated from the adult data. In adult literature, it's a well-known fact that VTE is an important problem in the adult ICU, and thromboprophylaxis is routine in a lot of the care bundles. Despite thromboprophylaxis, a meta-analysis has shown that the incidence of VTE in adult critically ill patients is as high as 12.7%. What about in children? If you look at the incidence in critically ill children, the incidence really varies depending on which study you look at. I'll go into detail later. And we know that the true incidence is probably underestimated because a lot of these studies are retrospective studies. And a lot of these studies only look at symptomatic VTE, and they're not looking at the asymptomatic cases, which are picked up on routine ultrasound. And studies have also shown that although the incidence of VTE is low in children, it has been increasing over the years. This is a very large study in the US that looks at 40 PICUs, and over a period of 7 years, the incidence have increased by 70%, up to about 58 cases per 10,000 hospital admissions across all age groups in pediatrics. In the critically ill children, as well as in trauma, VTE incidence varies greatly. You can see that it's as low as 0.2% in some studies, and up to as high as 27.8%. And this is a prospective single-center study in a unique population that has more cardiac disease. And as pediatricians, we all know that children are not small adults. And it's not even as simple as that. A neonate is different from an infant, and is different from a child, which is different from an adolescent. So it's really complicated for us to manage our patients. And this is especially demonstrated by the distribution of VTE that we see in our patients. There is a very clear bimodal distribution with the highest risk in the neonatal and infant age group, as well as the adolescents. And this is in a Korean study, but this is also shown in a US study. It's always a bimodal distribution regardless of which study you look at. To understand this developmental hemostasis, we need to look at the physiology behind hemostasis and thrombosis. Our body has a natural hemostatic balance. We have in our body the procoagulants, which are your clotting factors, tissue factors, as well as the natural anticoagulants, such as protein C, protein S, antithrombin 3, as well as the fibrinolytic system. And in order for a normal person not to bleed or clot, there must be a good balance of these procoagulants and anticoagulants. Developmental hemostasis is a concept that has been coined by Maureen Andrews more than 20 years ago. and when she looked at the levels of procoagulant proteins as well as anticoagulant proteins. And you can see that the vitamin K-dependent clotting factors are all low at birth and increases with age. The non-vitamin K-dependent factors are actually quite near adult levels. And the anticoagulant protein levels are also low at birth and increase with age. As a result of which, although both the clotting factors as well as anticoagulant factors are low in children, there is a good balance and they don't naturally clot or bleed. What about in Asia? There's actually limited Asian data. The existing data shows the incidence of VT in Asians is actually lower compared to Western population, such as in the Korean study, which is only 3 per 10,000. However, a more recent review by the Asian Venous Thrombosis Forum Work Group has shown that we are actually approaching Western population incidence. So if the incidence is so low, why is it still so important? It's because of complications such as extension of thrombus, pulmonary embolism, bloodstream infections, loss of vascular access, post-thrombotic syndrome, pulmonary hypertension, recurrent thromboembolic disease, as well as death. And the different types of VTE, other than DVT and PE, also have different complications. In renal vein thrombosis, it leads to renal failure. In cerebral sinovenous thrombosis, it leads to seizures, death, and also significant neurological morbidity. In portal vein thrombosis, they get portal hypertension. In children, unlike in adults, up to about 90% of children have a risk factor. And critically ill children with VTE have a median of at least 2 risk factors. And presence of a CVC is the single most important risk factor. This review looks at the different types of risk factors that we see in critically ill children. The top frequency are central venous catheter, surgery, congenital heart disease, followed by systemic illness, infection, trauma, and immobility, and then malignancy and others. And in this study, this group has looked at the presence of thrombotic risk factors in their admissions. These are not patients who actually have a VTE, but they're looking at the patients who have thrombotic risk factors. And the most common risk factors are CVC, infection, and age less than 1 and more than 14. And based on these risk factors and the number of VTEs the patients have from this group of 700 patients, they came up with a total thrombosis score for pediatrics, in which low risk is 0 to 1 risk factor, medium risk 2 to 5 risk factors, and the highest risk group with 6 risk factors. Since CVC is the most important risk factor, I'll go a bit into more detail. Up to 85% of cases of VTE are related to CVC in children. And the reason being the Virchow's triad. When there's a CVC, there's endothelial trauma from the time of insertion of the catheter. There's stasis of blood due to the catheter causing obstruction of the blood vessel. And there's also hypercoagulability due to foreign material with platelet adhesions and activating of the clotting pathway. And the highest risk factors are those with femoral CVC, percutaneous CVC, as well as multilumen CVC. There's also a complex relationship between infections and DVT. A patient who has infections because of the inflammatory cascade and all that would actually have a higher risk of thrombosis. And a patient who already has a DVT would actually be at a higher risk of infection due to infected thrombus, which will lead to a bloodstream infection. In pediatrics, we are aware that we also have unique pediatric risk factors that are not seen in the adult population. We have inherited or genetic thrombophilia. As a hematologist, I'm always consulted about whether we should screen for thrombophilia in the patient. Can this be a protein C, protein S, antithrombin deficiency? And really, this is really the minority of the population, as shown by the risk factors I shown earlier on. Because just being a carrier or heterozygote or heterozygous carrier of protein CS and antithrombin deficiency does not make you predisposed to VTE in a childhood or adolescence if there is no other risk factor. However, we still need to diagnose the really severe type of congenital thrombophilia, like in this case. This is a picture showing neonatal purpura fulminans, which is due to homozygous protein C deficiency, which is lethal if it's not diagnosed early. We also have the big group of cyanotic congenital heart disease. They are at risk of thrombosis because of polycythemia. The hypoxia itself leads to further endothelial damage. All these patients have interventions. They often have central lines. And also, there's also a low-flow system, like in a Fontan circuit. And if your unit does solid organ transplants, in liver transplants, thrombosis of the blood vessels is a feared complication that we have. In cardiac disease, it has been shown that the most significant risk factor is actually a single ventricle physiology with an odds ratio of 11, followed by arterial to somatic oxygen saturation gradient that's widened due to the more significant hypoxia. Interestingly, this study doesn't show that CVC is a significant risk factor, partly because probably most of the patients have a CVC anyway. In terms of prevention of VTE, what do we do? Common sense is early mobilization, remove the CVC if you no longer need it. But what about mechanical thromboprophylaxis that's actually used in a lot of units? There's actually no pediatric evidence. You can either use a sequential compression device or graduated compression stockings. And pharmacologic thromboprophylaxis, a lot of us are reluctant to use it because we're also concerned about the risk of bleeding, especially in patients who are post-surgical. In the adult population, there are actually good evidence for thromboprophylaxis in the ICUs, grade 1B evidence. However, in the pediatric ACCP guidelines, which are the most comprehensive guidelines that we have published in 2012, 9th edition, it actually recommends against routine use of pharmacological prophylaxis, except in certain situations, like prosthetic heart valves. But even in the other situations, it's actually only grade 2C. Recommendation, like in cardiomyopathy, renal disease, and cyanotic heart disease. However, a lot of units still have their own thromboprophylaxis protocol. This survey is done in US among 59, it started in US, but it's 59 PICUs in 7 countries that shows that although for patients who should receive pharmacological thromboprophylaxis based on consensus recommendations, only a third of them receive it. And mechanical thromboprophylaxis is seen in about a quarter of them. And the presence of cyanotic congenital heart disease and spinal cord injury strongly predicted use of prophylaxis. And some units, like the Cincinnati Children's Hospital, has also developed their own algorithm despite the lack of evidence. And in moderate and high-risk group, they recommend mechanical prophylaxis and consider pharmacologic prophylaxis in a high-risk group. In CVC-related VTE, there's currently no evidence for thromboprophylaxis. And what about heparin-bonded catheters? The evidence is also weak. There's only one paper that shows possible benefit in terms of decreased risk of thrombosis and decreased risk of infection. However, this benefit is not seen in infants in congenital heart disease. Diagnosis, we all know how to diagnose clinically if they are symptomatic, and otherwise imaging is by ultrasound. Venogram is still the gold standard, though rarely done, as well as CT and MR venogram. Therapeutic goals are to establish flow through the occluded vessel, prevent thrombus extension, prevent pulmonary embolism and recurrence. In terms of treatment, although it's recommended that we treat for 3 months, it's all from adult data. And ACCP also recommends that we treat for a longer duration if the risk factor is still present, like if the patient still needs a central line. There's currently an ongoing multi-center prospective RCT looking into duration, 6 weeks versus 3 months. It's a kids.dot trial. And for anticoagulants, for decades, we've been using the same medicines, unfractionated heparin, low molecular weight heparin, usually in terms of enoxaparin, oral warfarin. And now we are excited because there's a new agent. There is the DOACS, a direct oral anticoagulant, or the older name is NOACS. And antiplatelet really shouldn't have a role here because these are actually not anticoagulants. But we have a lot of challenges in anticoagulation due to developmental hemostasis. We know that antithrombin levels are low in children, so you need higher doses of heparin. Pharmacokinetics vary with age, with weight, and even with race, as seen in warfarin. There's a need for injections if you give heparin. There's interactions with drugs and diet with warfarin, and a need for frequent monitoring in terms of RNR and anti-10A levels. And the dosing recommendations are also quite confusing. Newborn, infant, child, adolescent, you can see that the doses are different for heparin, for enoxaparin, as well as for warfarin. The ongoing pediatric trials for DOACS, they're actually currently all ongoing. The adults have already started using it. It's recommended for use in stroke prevention, in AF, as well as treatment of VTE, and as well as thromboprophylaxis in like orthopedic surgeries. But in children, these are still ongoing trials, and a lot of them are only like phase 1 or 2. We're still doing PK studies in terms of the direct feather 10A inhibitors like apixaban, rivaroxaban. Edoxaban is a Japanese drug. Direct thrombin inhibitors like dabigatran is the phase 2 studies in adolescents have been published already. But the advantages for children are really that these are oral. They do not require monitoring of therapeutic levels and not adversely affected by diet. What about thrombolysis? We usually use TPA. However, there's actually no consensus in children regarding the dosing. It's debatable. It's just case reports. You can just pick and choose which one you want to follow. And it's only indicated in life-threatening and limb-threatening conditions, and it's contraindicated if there's a high risk of bleeding. So what is the future for thrombosis in children? We definitely need more pediatric studies. We need to look at the epidemiology, the incidence, the risk factors, and the racial differences for us in Asia. Pharmacokinetic data for newer agents is really important for the different age range, the neonates, the infants, the child, the adolescents, as well as for Asians. The adult studies have shown that for rivaroxaban, the Japanese need a lower dose. And which patients need thromboprophylaxis? What is the duration of anticoagulation? Maybe we only need 6 weeks. And the role of biomarkers. Take-home message is evidence is still lacking in pediatrics, and we definitely cannot extrapolate adult data to children because of the developmental differences. And due to the wide variation between different ICUs, we need to evaluate local incidence and risk factors before you decide on your own guidelines. And management must be guided by carefully balancing the risk and benefit in each individual case. Yeah. Thank you.